A very big hello to all my dear students. So let's continue with our T2O series. You're most welcome to your favorite channel, you and I, Dr. Ruchira. So what do we have in store today? So which clinical vignette are we going to discuss? Let's see that. Chalo, we'll read this together. Okay. So I hope you're making little notes or some recording something. Just don't keep watching the video as if it's a time pass. Okay. Or I will remember this. So it's like an important study. So when you're looking at my videos or you're studying with me, you should have a copy and a pen where you are noting down things, right? And another important thing I would like to suggest you is I have the protocol which I always follow is I always discuss thought for the days at the end of the session, right? You know that? So put all those thought for the days with you at one place. You are going, that is the most important part of the interaction. Believe me. Okay. It's going to go a long way. It is going to really help you. Okay? Chal. So let's start. A 30 years old female. So why it is marked? Because it is important. We are talking about a middle-aged female, right? Presenting with complaints of blurring of vision while reading and photophobia. Okay, in bright light. On examination, there is anisocoria, difference of pupil size, with a large regular pupil in the left eye. Both direct and consensual light reflex is absent in the left eye. The left pupil responds slowly to near with slow redilatation. Now, when you say slow redilatation, I think it should immediately click to you what are we talking about. We are talking about tonicity, tonic pupil, isn't it? So, how will you, and right eye, the pupillary response is normal. So the fundus is also normal in both eyes. Most probable diagnosis is. We have to think about the diagnosis one by one. If I am going to sort it out, I will sort it out this way. She is a middle-aged female. My patient is a middle-aged female, unilateral condition, complaining of photophobia and also difficulty in reading, right? And blurring of vision during reading, correct? That means there has to be whenever reading में blurring of vision हो रहा है, which means pupil size as it is written here, left pupil is mainly, it is given here, it is large and irregular. So we are talking about left eye, there is a problem where the pupil is almost large and regular. Let's see here, let's look at the patient. This is the patient. Can we see here? Right eye is fine, left eye is mid dilated pupil, right? So we are looking at a mid dilated pupil. Left eye mid dilated pupil. What is the diagnosis? Huh? Easy now? So when you are looking at the light and near reflex, what is happening? What was the history telling you is this. So when you're showing the light, look at here. It is not reacting to light. Almost nil, very, very sluggish, or it can be just absent, right? So that is one thing. Very sluggish or absent, you should note down. But here in this question, it is saying it is absent. Okay. When you talk about the near reflex, okay, this is okay, but it is again sluggish. And when you are removing the finger, even then, this is still constricted. It is not coming back to normal, isn't it? So the question is saying the slow redilatation, tonicity. So we are talking about what? We are talking about Holmes Adie pupil or tonic pupil, right? So everything in the question was mentioned, and this is how you will see the findings. ठीक है ना? Slow redilatation, normal pupillary response in the other. Generally, Holmes Adie or tonic pupil क्या होता है? It's the unilateral condition, and I think if I talk about specifically about the questions they ask you, is they have asked you about the position of the pupil in Holmes Adie. So position of pupil is always, you will answer, क्यों लगा लो? It is mid dilated. You have to know this, as you can see in this patient, right? Okay. Mid dilated pupil. What is the other question they have asked you? If you want to really confirm, okay, this is Holmes Adie pupil, which test are you going to do? Huh? And also one more thing, when you say anisocoria, let me first add here about anisocoria. Anisocoria is difference of the pupil size. Okay? Please keep this in mind. It's a tip. Anisocoria always occurs when there is any problem in the efferent pathway. Very quick revision. Please revise your pupillary light reflex pathway, all of you. So if I very quickly talk about it, I'm going to talk about it verbally only. So the two retinas, the visual pathway, you all know, nasal fibers decussate, temporal do not decussate, and after chiasma comes the optic tract. What happens to the pupillary light reflex? It will not go down into the LGV. From the optic tract, it is deviating to pretectal nucleus, then going to Adinga Westphal nucleus. ये आपका पूरा afferent path. Now comes the efferent from the Adinga Westphal. You go to the third nerve, inferior division of third nerve, nerve to inferior oblique, and then finally ciliary ganglion, short ciliary nerves, and iris sphincter. So the problem in Holmes Adie, where is it? It is in the ciliary ganglion or short ciliary nerves. So any lesion, this is the next important thing. It is the efferent pathway which is affected in this condition, and mainly the lesion here is either in the ciliary ganglion or short ciliary nerves. Okay, so once we know this, next important thing which I was talking about is about which test to confirm. So if you talk about which test to confirm, what will you answer? We give pilocarpine. Now pilocarpine, if you give, 1% is normal. If I put 1% pilocarpine in your eye, also the pupil will constrict. But here we are giving a very low percentage of pilocarpine, and even in this, the pupil constricts if this patient is a case of Holmes Adie. So in a little concentration also there is constriction. Why it is so? We all know this. Everybody is clear about your pharma. It is your denervation hypersensitivity, because of which even a very minor concentration of the pilocarpine, say the pupil is reacting. Okay? So that is your pilocarpine test. You will not forget it, please. This is important. INI-CT का exam का भी question रहा है ये, and I think it is asked very commonly in NEET PG or all types of exams. Okay. Okay. So that was the case today about Holmes Adie pupil. Now today I have not taken the IBQs. What we will discuss today is a very interesting thing. What are the different iron depositions and how do you have to learn it in the eye? Now why I took this? Because a lot of questions, repeated questions in all your exams. So we will talk about iron depositions in eye as our next heading. Now, before I start showing you the different iron depositions and what you have to know, why don't you learn it in my style? What is my style? Oversimplification. Simplify. Let's make ophthalmology very simple. How will you do that? We'll make a diagram. So all of you make a diagram with me. So if this is your... एक minute. Let me try again. So this is your cornea. है ना? Okay. This is your pupil. Basic हो गया? ठीक है? अब iron depositions, how to learn? Let's see. What we will do, we will draw it here. What are the things they can ask? There can be just a deposition between the middle and lower third of the cornea, cause being idiopathic. What is this known as? You just have to be familiar with the terms. So, middle and lower third of the cornea, cause is idiopathic. We call it Hudson-Staheley line. Just know this. Hudson-Staheley line. It is idiopathic. No disease or something. We don't learn it with some disease or something. When any pathological condition, right? Then we talk about next हम पढ़ेंगे which iron deposition, all of you. Okay, let's say pterygium. So now it is associated with a clinical condition, and that is pterygium. In pterygium, what type of iron deposition जो आपके head of pterygium पे, this is what is called Stocker's line. So we will draw here. We will write here. This is your Stocker's line. Okay, then we come to the next iron deposition. That happens after if you have done a trabeculectomy in a patient. Trabeculectomy, commonly done in the glaucoma patients, you know this, right? So when you are doing a trabeculectomy, एक filtering bleb बनता है, correct? So the filtering bleb that is formed here, I cannot go into details of that, revise your glaucoma chapter. So when this filtering bleb कुछ नहीं होता, that is just an elevated part of conjunctiva. Okay? So that, like a blister, it is elevated because the aqueous is flowing through it, because you have created a fistula while doing a trabeculectomy. So I'm explaining that. So this bleb formation, around that when you get an iron deposition, अब इसको हम क्या बुलाएंगे? We call it filtering bleb, Ferry's line. Okay? Let's learn it like this. filtering bleb. This is the filtering bleb we are showing. Oh, sorry, let me say the Ferry's line. लिख दो ना. Okay, let's write it here. This one is called Ferry's line. Okay. So now we know three types of iron deposition terms, and of course, how can you forget Fleischer's ring? So for that, we will make another small diagram here, and we can show it very clearly that okay, if there is a keratoconus in this patient, which is a conical protrusion of the cornea, at the base of the cone, this iron deposition is what is called Fleischer's ring, right? Case of Fleischer is copper, don't get confused, okay? So we are talking about Fleischer's ring. Next thing, what next they are going to ask you. So that next important thing is where are all these iron depositions? Keep in mind it is epithelial layer, okay? In the cornea, it is all in the epithelial layer. Okay? This is also a cue. I generally discuss always towards your question oriented things only. Right? Okay, so once we know all this, anything else that they ask you about iron in the eye? Yes, when the iron is going intraocular. So when it goes intraocular, what is that condition known as? Siderosis. है ना? So when you say siderosis, okay, we'll take the points when we come to the slide of siderosis. There, what are the things? Ask and examine what you have to remember. So it is iron inside the eye, intraocular foreign body, it is called siderosis. Itne iron depositions you should know. Okay? Okay. Now let's have a look at the slides here. So this is the Fleischer's ring. Everybody is clear? Quite. I don't think there's any confusion. This is what is called Fleischer's ring, right? So Fleischer's ring, what was the Fleischer's ring? In patients of keratoconus. Look at this one. So there's a filtering bleb, and on the filtering bleb, when you get this type of iron deposition, here you can see here, this is Ferry's line will be, so it doesn't matter, idhar hai ki udhar hai, just anything around the iron deposition, anything around the filtering bleb, just keep in mind is Ferry's line. Okay? Uske baad, we come to the stalkers. So this is stalk. Iron deposition, again, at the leading edge of the pterygium is this iron deposition. Can you see the reddish line that you can see? The arrows are already there. So this is what is stalker's line. Okay. Then we talk about next is here. What is this? Can you see this faint red line with the yellow arrows are indicating? This is your Hudson-Staheley line. जो अभी हमने पढ़ा था. ठीक है? So this is what is Hudson-Staheley line. चलो. अब आते हैं siderosis में. Siderosis is iron inside. Can you see here? So first thing, what are the things they have asked you about siderosis? We'll first take that. पहली चीज about siderosis. First, if I talk about a question-oriented discussion here, first important thing is, what is the first sign of siderosis? It is lens pigmentation. So can you see the iron green arrow showing you the iron deposits on the lens? That is the first. Then comes your iris pigmentation. And finally, what you see is it involves the retinal function. Okay, affects the retina. So this is important. Second important thing they've asked you is, okay, a patient has got siderosis. Now, how are you going to monitor what is the damage happening inside the eye? You are not able to take it out. You have to monitor. So what investigation I should see to know how much damage has happened to the eye? Now here comes the role. The retina we have to monitor the retinal changes. So what is the answer of this question? Serial electroretinogram. Correct? So serial electroretinogram जब करोगे बारे what you will see? You all remember electroretinogram? ERG, there is a A wave, then a B wave, and a very small C. A corresponding to photoreceptors. B bipolar cells and Muller cells. So bipolar cells corresponding to the activity of bipolar, B for B is B wave. And a very small C, which is we don't generally discuss in ERG, is corresponding to the retinal pigment epithelium activity. But yes, this question has been asked about ERG, that A wave corresponds to, you will say rods and cones activity is A waves. So we solve one more question here. So what will you say on a serial ERG? You will say diminution of the B wave. Okay, so decreased amplitude of B wave means now damage has progressed. Okay. So decreased amplitude of B wave. We will remember this, please. It is decrease amplitude of B ray. Okay, so these are the two questions. And if suppose one more thing I just remembered, if they ask you which is the most dangerous foreign body in the eye, intraocular foreign body, so please don't answer iron, then you will answer it is copper. Because pure copper can directly lead to phthisis bulbi, shrinkage of the eyeball. Okay? Okay. So this was all for today. I hope you enjoyed the discussion. And as I said, we are going to end the discussion by a thought for the day. Please note all these thoughts for the days. So when the days are difficult and when you feel low, just reading them, you're going to stand up again. The purpose of discussing is this only, that it helps you in all ups and downs and in difficult times as well. Right? We all need some inspiration and encouragement. We are all humans, right? Okay, so let's read this, what I have for you today. So let's apply this. All rivers, irrespective of their differences, flow unceasingly towards the sea. So, rivers, they don't stop. Patthar aa gaya, whatever obstacle is there, the river keeps flowing. It finds its way in spite of all the obstacles. You have to become like that and keep moving. You cannot get discouraged and stop. First of all, you should know this. Okay? And what else you have to understand, that if we also continue to make these consistent efforts, we will eventually reach the ocean of happiness. Where you want, what we mean to say here is whatever achievements and victories are only possible with persistence and perseverance. Okay? The important thing is to do everything you possibly can. Ask yourself, every morning you should really ask yourself and reassess yourself, how can I be a better person today than yesterday? How can I do something better than yesterday? How can I just even move a 1 inch more than yesterday? If you have that attitude, you are unstoppable. Nobody can stop you. Okay? So, but you have to focus on yourself, polishing yourself. Okay? Don't keep comparing around you. That's not, try to avoid all negativities. Try to focus on yourself and be positive. Okay? So you will be more surprised than anyone at how much you can achieve. You possess such unlimited potential. And believe me, each and every one of you has such unlimited potential. You all have to shine in your own way, not in any other person's way. Correct? Hope you got it. So thank you so much. Stay blessed and keep smiling.